Good afternoon, everyone. Today's topic is mechanical ventilation, the basics. So what is mechanical ventilation? Mechanical ventilation is a life support technique used to assist or fully take over the breathing or work of breathing from the patient. Typically, positive pressure ventilation, which moves the air into the lungs. So what are the basic goals of mechanical ventilation? One, it is to ensure adequate oxygenation, that is maintaining the arterial partial pressure of oxygen greater than 60 millimeters of mercury, and maintaining adequate ventilation, that is trying to maintain the carbon dioxide levels between 35 to 45 millimeters of mercury. And finally, reduce the work of breathing. So what are the common indications for mechanical ventilation? One is acute respiratory failure. Type 1 respiratory failure, where there is hypoxemia, where the PaO2 is less than 60 millimeters of mercury with a normal or a lower PaCO2. Typical examples are ARDS, pneumonia. So you want to increase the oxygenation for this patient. And type 2 is where oxygenation is normal, but patient is retaining carbon dioxide. PaCO2 is greater than 45 millimeters of mercury. Example, COPD, neuromuscular disorders. Another indication for mechanical ventilation is neurological impairments. Basically, where the GCS is below 8 is an indication for mechanical ventilation. It could be due to brain injury, stroke, GB syndrome leading to decreased respiratory drive. Other indications for mechanical ventilation are trauma with or without airway compromise, like without airway compromise but injury to lung, shock states, like cardiogenic septic hemorrhagic shock. Here we are more concerned about the oxygen delivery may be impaired, so we want to increase the PaO2 here. Severe acid-base imbalances, especially metabolic acidosis. So when there is metabolic acidosis, patient needs to reduce the H+ ion concentration or to increase the pH value. Patient tries to expel carbon dioxide. So he'll go into hyperventilation, where work of breathing may result in stress and failure. So in these cases, we can use ventilation to take over the work of breathing. Or in cases where there is an impending respiratory failure, where there is progressive hypoxia, hypercapnia, or fatigue. So what are the types of mechanical ventilation? So mechanical ventilation types can be both invasive or non-invasive. Invasive mechanical ventilations are CMV, control, mandatory ventilation, such as pressure control or volume control. Assist control mandatory ventilations, such as pressure assist or volume assist control mandatory ventilation. Intermittent mandatory ventilations, SIMV. Support ventilation, like it could be either pressure support or volume support. Mostly we see pressure support ventilations. Non-invasive ventilations are either continuous positive airway pressure maintenance or bilevel positive pressure airway maintenance. So these are the traditional modes of ventilation. CMV modes, like depending on what we are controlling, either we are controlling the volume or we are controlling the pressure, or adaptive controlling, where it can be either pressure or volume depending on the patient status. So CMV modes are volume CMV, pressure CMV, and adaptive CMV. SIMV could be again volume SIMV, pressure SIMV, or adaptive SIMV. And support modes, pressure support or volume support. So volume controlled ventilation, one of the CMV description. It delivers a predetermined volume of air with each breath, regardless of pressure changes. So in these patients, like we set a tidal volume, and this amount of tidal volume is delivered to the patient at the regular intervals based on the respiratory rate we have set to the patient. It doesn't, without bothering about the pressure changes in the lungs. Currently, we have an option to limit the maximum pressure that can be set. So it will try to deliver the exact amount of volume we have set. Advantages are consistent tidal volume is set, and it is useful in patients with stable lung mechanics. Disadvantages, there could be over-distension in patients where lung compliance is altered, and there is a potential for barotrauma. Like the larger volume of air that is delivered, alveoli will there is a chance of over-distension of alveoli and rupture. Pressure control ventilation is where during inspiration a set pressure is reached, and tidal volume varies depending on the lung mechanics. How compliant the lung is. If the lung is more compliant, more volume will be delivered. If it is less compliant, tidal volume will be less. So what are the advantages? Because the pressure that is reaching the lungs is going to be set, there is a very low risk of barotrauma per se. Disadvantages, tidal volume can vary. So if the lung is not compliant at all or reduced compliance, in those cases, the tidal volume we require may not be delivered to the patient. So controlled mandatory ventilation could be genuine controlled mandatory ventilation, like volume controlled or pressure controlled we had discussed earlier, or it could be assist controlled. Basically, what assist controlled means, there are two ways the ventilator will start delivering a breath. One is you set a timer or you set the respiratory rate and time cycling occurs. So at every certain interval, ventilator will start initiating a breath. The other ways, the trigger can be from the patient. So patient initiates a breath, and the moment ventilator detects that a patient has initiated breath, it will deliver the set tidal volume. In ACMV modes, the tidal volume that the ventilator will deliver when the trigger is patient will be the tidal volume you have set. The change between SIMV and ACMV is that in SIMV, when the patient initiates breath, the amount of breath that is delivered will be dependent on the patient. Like in SIMV, certain amount of pressure will guide the air in. But in controlled mandatory ventilation, when the patient initiates the breath, in ACMV, the tidal volume you have set will be delivered. So, provides a set number of mandatory breaths that allows for additional spontaneous breaths if initiated by the patient. So, if the patient, how the ventilator will detect if the patient is initiating the breath is, it could be either pressure changes or it could be the flow changes. Advantages is it reduces the work of breathing. That is, the moment patient initiates the breath, ventilator will push the air in, like it will increase the pressure and the air will be this. So work of breathing will be taken over by the ventilator from the patient. And because we have set a mandatory amount of ventilation, so we have ensured that the minimum ventilation to the patient can be delivered. Disadvantages is risk of hyperventilation can lead to patient ventilator asynchrony. So if the trigger for when the patient is initiating breath is put in too low, right? So even sometimes, like if it is put very low, like around 1 liter per minute, even cardiac pulsations can trigger a ventilatory, can initiate a breath. So in those cases, patient will start getting hyperventilated. Other modes are pressure support ventilation. Basically, pressure support ventilation is there will be certain amount of positive airway pressure during the inhalation stage of the patient, right? And if you have set a PEEP, like PEEP is positive end expiratory pressure. So you have set a PEEP of 5 centimeters of water. So the entire cycle, the minimum guaranteed pressure support will be 5 centimeters of water. But when the ventilator detects that the patient has initiated a breath, it will support it with another additional 15 centimeters of water pressure or 10 centimeters, whatever you have set. So the advantage is because most of the work you do, like inhalation is active, exhalation is passive. So when you are breathing in, when you are taking in, additional pressure support will help you taking the breath easier. So that will reduce the work of breathing. Disadvantages is it is not suitable for patients with weak respiratory efforts because you have to set a trigger, right? If the trigger is not, if it is not triggered, then respiratory drive is low, it will not be able to help with the initiating a new breath. The other is continuous positive airway pressure. Again, PEEP is an example of continuous positive airway pressure. So it maintains a continuous positive pressure, but here you have to remember that in CPAP, like in continuous positive airway pressure is only delivered during the inhalation process, right? During exhalation, the inhalation part is cut off and passive exhalation can occur. If you want to maintain PEEP, you'll have to maintain, the valve will be changed in the exhalatory part of the ventilator. Advantages is improves oxygenation, reduces work of breathing, and this is very useful in obstructive sleep apnea and certain forms of hypoxia. Like OSA, what happens is soft palate will fall down and will obstruct. So continuous positive airway pressure, at least when the initiate breath is, it will push the palate upwards and so it will clear it. Disadvantages is does not provide ventilation, requires patient ability to maintain spontaneous breathing. Like one of those absolute indications for starting a patient on CPAP is patient has to be conscious and patient has to initiate breathing. This is the reason why. So what is synchronized intermittent mandatory ventilation? Like ACMV, we have said that we'll set in some amount of mandatory ventilation. What is mandatory ventilation? Mandatory ventilation is basically, we have given the orders to the ventilator that this number of breaths will be delivered to the patient per minute, right? So we usually SIMV mode is, we'll put in around 8 to 10. Like higher modes you can put in when the patient is completely paralyzed. SIMV works perfectly as ACMV, but there you have to put in the rate around 15 or 20. Like SIMV currently can be used for all kinds of ventilation. Other than CMV modes, SIMV is exactly same as ACMV provided respiratory rate is high. So SIMV is, you have put in certain number, like suppose let's say 8. So per minute, the ventilator will deliver 8 mandatory ventilations, right? These breaths are triggered by the ventilator. And between each breath, there will be a period gap, like time period will be allowed. In this time period, provided the patient initiates a breath, the ventilator will give some pressure support so that patient can inhale. So patient, between what you have set, additionally whatever the patient is trying to breathe, those can be added. So as the patient becomes more conscious, has more capability to breathe more, right? You start decreasing the SIMV, what you have set, the rate. Like from 8, you will decrease it to 6 to 4 to 2. So if you put it at 2, basically what it means is the ventilator will provide 2 breaths irrespective of the status of the patient. And the rest of the breaths, when the patient starts taking in breath, it will provide pressure support. So as the patient condition improves, you can decrease the SIMV. This is like weaning. When you want to wean the patient off a ventilator, what you want to do is, you want to gradually decrease the work ventilator is doing and allow the patient to start breathing more and more, right? So, but we want a safety net that this much mandatory ventilation. So if the patient is apneic, this much ventilation will be delivered by the ventilator. So advantages are promote spontaneous breathing and can be used as a weaning mode. Disadvantages is requires careful monitoring to ensure adequate ventilation. Like you have set it at 8, you think the patient is improving, so you have decreased the thing. But if the patient, patient is not taking in breath, you have decreased it to 6 or 4. So now per minute you are only delivering 4. So you have to monitor and see to it that if the patient is not able to maintain what you think as adequate minute ventilation, you'll have to start increasing the respiratory rate in SIMV. So you have to monitor closely when the patient is on SIMV. And if the patient is doing more, like taking both, the minute ventilation will vary, right? And minute ventilation is important because minute ventilation is one of the things we use to control the pH, right? So amount of, basically ventilation is amount of carbon dioxide you're breathing out, right? So if the ventilation decreases, obviously carbon dioxide will start increasing in the blood, so pH will fall, acidosis will occur, right? So SIMV mode indications, patients with who are very passive, that is like completely paralyzed, patient is not initiating breaths. In these cases, we can set a high rate, respiratory rate. This will work as ACMV here. On partially active patients, again, we'll start with a high set rate and we'll slowly decrease the rate. And as the patient becomes more active, we will reach a low set rate before converting into pressure support so that we can wean the patient off the ventilator. Again, these are not set standards, but these are rough guidelines to initiate. Like patient has come with ARDS, what kind of mode do you want to select? So in ARDS, we want low tidal volumes. So 4 to 6 milliliters per kg body weight. Again, this weight is not the actual body weight of the patient, ideal body weight of the patient, right? You understood or just blankly? Ideal body weight of the patient. So calculate further ideal body weight of the patient and 4 to 6 milliliters per kg with high PEEP. In COPD exacerbations, like you have COPD exacerbation patients right now in the ICU, right? So for those patients, so if it is non-invasive, we start with bi-level positive airway pressures. And if you want invasive support, you start with SIMV, with pressure support. in cardiogenic pulmonary edema cases. Again, non-invasive, go for both CPAP and BiPAP will be useful here. If you want to intubate and ventilate the patient, there go for pressure control with moderate PEEP. Neuromuscular weakness, pressure support ventilation or volume control ventilation, both of them will work here. So again, like I was saying, like patient is passive, partially active or active patient, depending on as the status of the patient changes, you can change it from CMV to from ACMV to SIMV to pressure support. If the patient is completely active, pressure support is much more tolerated by the patient than a ACMV mode. Right? Partially active patients, you want some mandated minimum ventilation, so you can go for ACMV or SIMV modes. And completely passive patients, ACMV, like CMV ventilation is used to be the gold standard there in completely passive patient, but right now ACMV is also used widely. So what are the parameters you set on a ventilator? Tidal volume. Typically you set it at 6 to 8 milliliters per kg of predicted body weight or ideal body weight. You have to know how to calculate for males and females and based on height, right? In ARDS conditions, lower tidal volumes can be set. Respiratory rate, again, this is set to achieve specific minute ventilation, and we plan respiratory rate based on the pH the patient has. Like the pH and PCO2 levels, we want to adjust it based on the, to adjust PCO2 levels, we use respiratory rate as the parameter we'll change. FiO2 is fraction of inspired oxygen. That is 21% in normal air. Up to, you can go up to 100%. But high FiO2s can cause damage to the lungs. So your target SpO2 should be between 92 and 95%. More than 95%, try to decrease the FiO2 so that it is not above, SpO2 levels are not 98, 99. If you see the SpO2 levels 98, 99, try to decrease the FiO2 so that you want it around 92, 95. PEEP, positive end expiratory pressure. This is the pressure maintained at the end of expiration, right? So what does that do? If there is some positive end, there is some amount of air in the lungs, right? So it will prevent collapse of alveoli. Also, if the pressure at the end of expiration is equal to atmospheric pressure, right? Next breath initiation will be slightly harder. If you have some PEEP, it will decrease the work of breathing. Also, recruited alveoli can collapse. Like what is recruitment of alveoli? Alveoli that have been collapsed, you're giving some positive pressure and you're trying to recruit them. You're opening them up, right? Again, if the pressure goes back to zero, they may collapse again. So to again re-recruit them, you'll have to put in more effort. But if you keep a positive PEEP, those will not completely collapse, and so you'll maintain recruitment there. Inspiratory ratio or IE ratio, usually set in 1:2 or 1:3 in normal ventilators, right? I/E ratio is like, suppose you have set in 10 breaths per 1 minute. So each breath is going to take 6 seconds, right? So IE ratio is 1:2 means inspiration time is going to be 2 seconds, expiratory time is going to be 4 seconds, right? 1:3 again, 2.4 was 3.6 like that, right? So you can adjust that. So if in cases of, if you want to recruit patients or if there is VQ mismatch, you want to have a higher I ratio compared to the E ratio, right? So you want higher inspiratory time because you want to, again, inspiratory part is two types. One is where the flow is there, so you are delivering it, and then the inspiratory pause, where the delivered air stays in the lungs. So if you increase the inspiratory pause time, there will be more time for diffusion across the alveolar membranes, alveolar arterial membranes, right? Peak pressures, like this is the high, like in the graph you'll see this is the highest pressure delivered, right? So peak pressures basically are symbolic of amount of pressure it requires for the oxygen or air or whatever gas to be delivered to the alveoli, right? Higher peak pressure requirement means you need to work more for the gas to reach the alveoli, right? And plateau pressure is basically equivalent to alveolar pressure. So if you suddenly notice peak pressures elevating in a patient, You have intubated the patient, patient is on ventilator, you have noted the peak pressure. Suddenly you see that peak pressures are increasing. That means ventilator is working harder to send the same amount of volume to the lungs, to the alveoli, right? So if it is working harder, that means there should be some kind of obstruction, sometime restriction somewhere for the air to. So you, the moment you see sudden rise of these things, check if there is any kinking of the tube, check if there is any fluid in the tubes or the thing, or it could be bronchospasm. So that is one of the things you have to monitor when you have a patient on ventilator. Plateau pressures usually measured during inspiratory hold. Basically, you have delivered the oxygen and you hold further flow. Now it will balance out. So that pressure will be equivalent to whatever the pressure that is in the alveoli, right? So you want to keep that less than 30 centimeters of water, right? Because more than 30 centimeters of water, there is a chance of barotrauma. So you have intubated the patient, you have set the mode. So what care of a ventilated patient, right? Like fast X in bed, I'm sure you have all read that in the ICU. But so basically I'll talk about 3 points. One is ventilator associated pneumonia prevention, right? So what do we do for that? We elevate the head to 30 to 45 degrees. Unless the patient has hypotension or is in shock, every ventilated patient should have head end elevation, right? Daily sedation vacation. Like, what is sedation vacation? Like in ACMV or CMV modes, you will have to deeply sedate the patient. SIMV patients, obviously you will not sedate the patient, but if the patient is going to be sedated deeply, you want to give a window of period where you stop sedating the patient, right? And why do you want to stop sedating the patient? Because once the patient is sedated, respiratory drive will be down, right? You give a sedation window, sedation-free window, check if the patient is getting ready to decelerate, like whatever from ACMV to SIMV to pressure support, right, to wean, right? Subglottic suctioning and chlorhexidine mouth care and use of early mobility protocols. All of these help in preventing ventilator-associated pneumonia. Sedation and analgesia. So target is patient should be sedated, but you should try to minimize sedation to maintain spontaneous breathing. End goal of putting the patient on ventilator is to remove the patient from ventilator, allow him to breathe properly. So use sedation scales, and then ventilator associated lung injury. That is to prevent barotrauma by monitoring the plateau pressures, avoid volume trauma with low tidal volumes, and prevent atelectative trauma by having PEEP, right? So that is care of patient on a ventilator, right? Now you want to wean the patient off the ventilator. So what are the criteria for weaning? One is hemodynamic stability. Patient should have stable vital signs without any inotropic support, right? Patient maintaining blood pressure with inotropic support is not a candidate for weaning. Adequate gas exchange, so normal or near normal ABGs. Neuromuscular function, patient can initiate breath and maintain the airway. Spontaneous breathing, PaO2 by FiO2 greater than 150. That means moderate ARDS. So less than 100, if PaO2 by FiO2 is less than 100, that means severe ARDS is there, right? 100 to 200 is moderate, 200 to 300 is mild, greater than 300 is normal, right? With that PaO2 by FiO2 greater than 150 with PEEP less than 5 to 8 centimeters of water and FiO2 less than 0.4. Hemodynamic stability without vasopressors, and patient is awake and able to follow commands, and minimal sedation is required. So what are the weaning strategies? So gradual reduction, like in fast X in bed, deceleration phase, right? Gradual reduction, so slowly decrease ventilatory support while monitoring patient's response. Spontaneous breathing trials. Success of spontaneous breathing trials is he has to tolerate it for 30 to 120 minutes with stable vitals and no significant distress. Modes of weaning are gradually reduce SIMV to PSV and decreasing the pressure support, right? SIMV as weaning has not shown any benefit if you use only SIMV as criteria for weaning. What are the adjunctive therapies in mechanical ventilation? Prone positioning. So it will increase decrease VQ mismatch, and there are physiological benefits in severe ARDS. ECMO, again we do not have ECMO here, so but refractory hypoxemia or hypercapnia, you'll have to go for extracorporeal membrane oxygenation. Sedation, neuromuscular blockade to balance patient comfort, synchrony with the ventilator, and minimizing respiratory muscle atrophy. And inhale pulmonary vasodilators like nitric oxide and prostacyclins to manage pulmonary hypertension in ventilated patients. So we'll go through few case scenarios, especially case we see regularly in ICU. So a 55-year-old male with septic shock from intra-abdominal sepsis has occurred. He's been intubated due to respiratory failure in the casualty. So what mode do we select? And what are the rationale behind it? So ventilation strategy modes are either pressure controlled ventilation or pressure regulated volume control, PRVC or PCV, right? Why PCV? Septic patients in shock are at high risk of hemodynamic instability. Positive pressure ventilation reduces venous return, especially in shock patients who are already fluid depleted or vasodilated. PCV limits peak airway pressures. So we avoid decreasing the return, right? So preload decreases are avoided that way. Lower pressure reduces risk of ventilator-induced lung injury also, which is critical when lungs are susceptible to further injury. This mode ensures that pressure limit is not exceeded, minimizing chance of over-distension of alveoli, which could further impair oxygenation and perfusion. PRVC mode. Ventilator adjusts the inspiratory pressure based on lung compliance to ensure the constant tidal volume, right? But it while maintaining the lowest necessary pressure. This is important in septic shock because lung compliance may fluctuate in capillary leak and pulmonary edema as capillary leak and pulmonary edema evolve, leading to dynamic changes in oxygenation and ventilation. It also prevents overpressurizing the lungs, reduce risk of high intrathoracic pressures, and subsequent reduction in cardiac preload and venous return. So tidal volume settings around in shock patients, right? So 4 to 6 milliliters on predicted body weight. Minimizing Wheelie also helps in to preserve the lung integrity, and avoid further contributing to systemic inflammation. FiO2, for these patients we start with FiO2 of 100%, and to ensure, again, shock is decreased perfusion, decreased tissue oxygenation is one of the main worries, right? So we start with 100% and reduce it. The goal is maintaining around 92 to 95%. PEEP is required to keep the alveoli open, but we want low PEEP in these cases, right? 5 to 8 centimeters of water, and titrate based on oxygenation goals, right? Excessive PEEP can result in further hypotension, so you have to note that. Patient comes with ARDS, right? Again, here PF ratio is basically PaO2 to FiO2 ratio is 90, which means severe hypoxemia is there. So again, in these cases, what modes of ventilation are required? Right? Recommended again, pressure control PRVC or PCV here also, right? PCV helps, rationale behind it is PCV helps to control airway pressure, minimize barrier trauma, which is critical in ARDS. You want to have enough pressure but not too much pressure, right? PRVC again, same as here, to prevent ventilator-induced lung injuries. As discussed before, for ARDS cases, we want low tidal volumes, 4 to 6 milliliters per predicted body weight. Maintain the plateau pressure of less than 30 centimeters. Plateau pressure is pressure in the alveoli. So you want to maintain it less than 30 centimeters. And PEEP titration can be based on compliance to keep the alveoli open, but to avoid over distension. So here PEEP will be around 10 to 15 centimeters of water. In ARDS patients, additional strategies that can be used to a ventilated is to prone positioning to improve oxygenation and reduce VQ mismatch, ventilation perfusion mismatch, and neuromuscular blockade to decrease the work of breathing so that the ventilator will take over the work of breathing. 70-year female has presented to the ICU with COPD exacerbation, right? ABG source 7.25 with PaCO2 85, so respiratory acidosis is here. Non-invasive ventilation is not working, right? So for these patients, you want SIMV. You do not want to paralyze the patient. You want, you'd rather have a SIMV mode. Again, neurally adjusted ventilator assist is not available for us, so we'll not discuss that. So these patients, so You have a patient COPD exacerbation means mode will be usually in SIMV, right? So again, the advantages of SIMV, like mandatory breaths are guaranteed and patient efforts will be allowed. This is useful in hyperinflated lungs. Exacerbation COPD patient will have hyperinflated lungs, right? Pressure support to help overcome airway resistance. So what are the settings we use for these patients? Low respiratory rate to prolong exhalation. Tidal volume 6 to 8 milliliter per kg body weight to avoid over distension, and moderate PEEP to prevent small airway collapse. Additional strategies for these patients are bronchodilator therapy and monitoring of hyperinflation, like assessing intrinsic PEEP and adjusting IE ratio accordingly. Like you want to give IE ratio from, if 1:2, you want to make it 1:3, you can go for up to 1:4 also. Neuromuscular disorder in a 45-year-old male, GB syndrome patient with progressive respiratory failure. So you know that problem here is muscles are weak and patient is not able to maintain adequate ventilation. So patient has a hypercapnia, PaCO2 of 65 and shows signs of impending failure. So again here ACMV or pressure controlled ventilation here. Because patient is not able sometimes patient will not be able to initiate breaths also. So here you have to go for SIMV may not be that beneficial here, you have to go for PCV or ACMV. Again, beneficial preset number of breaths is guaranteed and allows continuous peak airway pressure which will limit pressure but adequate tidal volumes. Tidal volumes here, the settings you use here are VT at 6 to 8 ml per kg, maintain low PEEP to avoid overinflating the lungs but enough to keep airways open. So PEEP will be around 5 centimeters of water, adjust FiO2 to maintain saturation again of greater than 92%. In these cases, like in cases of like Guillain-Barré syndrome or muscular dystrophies, monitoring of ventilator-induced diaphragm dysfunction should be done and early physical therapy should be started. Post-op ventilation in a 60-year-old male post-cardiac surgery. So basically you want to give ventilation to tide over post-paralyzed during surgery, right? So he SIMA modes here. Usually by the time patient is coming out, patient has is slowly coming out of drugs like either rocuronium, whatever this thing, right? Neuromuscular blockers. So you start with the SIMV, and once you think a patient is able to initiate breaths, switch over to pressure support ventilation. Usually they'll require up to 12 to 24 hours post-op ventilation to ensure safety, right? Again, 6 to 8 milliliters. This is again basic settings for these patients. VT at 6 to 8 ml per kg, PEEP at 5. Try to maintain the SpO2 92 to 96% with FiO2, and gradually reduce on SIMV, right? So gradually reduce the respiratory rate to increase spontaneous effort. Early mobilization and hemodynamic monitoring should be done for these patients. Acute, what is this? Severe asthma exacerbation, right? Status asthmaticus, before we used to say that status asthmaticus, right? So patient is presented with high PCO2 levels, 75 millimeters of. So here we need pressure controlled ventilation but here the important part is we want to ensure expiratory IE ratio, you have to maintain it 1:4. Sometimes 1:5 is also done, right? We want to give enough expiratory time to avoid high peak airway pressures caused by bronchospasm. Volume control can be used to prolong expiratory phase. Setting tidal volumes 4 to 6 millimeters, and PEEP should be set minimal to avoid further air trapping. In severe asthma, air trapping can occur, right? So there is almost no chance of collapse per se. Small bronchioles are already constricted, right? So air, you do not have, you're not able to send the air out of the lungs, right? So collapse chances are low. So PEEP can be minimal. Bronchodilators and monitoring for auto PEEP here. Same as ARDS, remember that. Thank you.